All right, take us away.
Okay, so starting with the case, it is a case of a 94-year-old lady who presented to the emergency department with altered mental status and new onset right eye gaze deviation. Should we stop here or?
Yeah, this seems like a great place to stop. Charmise, what are your thoughts?
Uh, all right. And was it 94 or 54?
It's 94.
Okay,
94.
wonderful. So 90 years of life. That's a lot of life there. Um, so we have a 94-year-old who's for now, I'm just gonna think about this as an acute altered mental status who's coming in with right eyes gaze deviation. So in terms of altered mental status, as you get older, and you have a lot of life and wisdom and medical issues sometimes that accompanies it, more things can make you altered, right? In a healthy person, younger person, maybe like something like constipation or something like a pneumonia or anything else wouldn't necessarily make you altered. But as you get older, it's much easier for people to get altered, especially if they have underlying dementia and everything else. I oftentimes of acute altered mental status, I often think of mist. But when I see the a right eye gaze deviation, I immediately think about what is no misdiagnosis in terms of central processes. So this is someone who's coming in with altered mental status and right eye gaze deviation. And the thing that I want to just right off the bat, even system one thinking, is that I just want to make sure this person is not having a brain bleed or something like a subdural hemorrhage or something like that. So this is someone that I would prioritize getting imaging faster, to just make sure to rule that out and then take a step back and say like, hey, do we need to separate these two entities? Are those related? But for me, that is going to be my first step. Jack, what are your thoughts?
Yeah, I am right there with you. I think prioritizing imaging runs paramount here. One of the things that I'm really curious to see how this unfolds, which I think we'll get more from in the history, is whether or not this ends up being both eyes deviated to the right, or if it's a single eye in which we're seeing some almost like a disconjugate gaze. Because if we start to see altered mental status plus a single eye that maybe occupying an abnormal position, right? Whether that's a down and out deviation, right? We might start to also think about cranial nerve palsies. For example, a third cranial nerve palsy characteristically has a down and out appearance, because if we remember, the third cranial nerve involves sort of medial movement of the eyes as well as upward movement of the eyes. And so if we knock out the third cranial nerve, we can see that sort of down and out appearance. Whereas, for example, a sixth nerve palsy, right, may actually involve problems where the eye actually is focused more medially as well. And so I think what you were saying, Sharmeen, is we're saying this is altered mental status plus a new neurologic deficit, right? We're gonna prioritize an intracranial cause of altered mental status as opposed to a systemic disease that's causing altered mental status, because of the high probability of an intracranial process that we have with gaze deviation, whether that's from a seizure episode, which could sometimes involve both eyes moving to one side, or a new cranial nerve palsy, which may involve just one eye moving to one side. So I am right there with you.
Okay. So can I move over to the next second aliquot?
That sounds great.
Okay, so the present history is that she presented to the emergency with these chief complaints, and she had been altered for 2 to 3 days prior to admission as per family. And she had baseline dementia as well, as reported by the family. Earlier in the day, she also reported to have one episode of coffee ground emesis, after which she became unresponsive and emergency services were called. She was also found to be in atrial fibrillation with rapid ventricular response, and family also mentions that she had been febrile. And now moving over to the past medical history, it had congestive heart failure, atrial fibrillation, peripheral arterial disease, CKD stage 3, hypertension, hyperlipidemia, diabetes mellitus with complicated peripheral neuropathy, and blindness and a left subdural hematoma. Moving over to the social history, she has no history of smoking or recreational drug use or any alcohol use, but she had multiple falls recently. Family history is non-contributory. There is no relevant family history. She had a surgical history in the past of an ORIF of right distal fibula, that is open reduction and internal fixation. So, and the medications she take is Tylenol 650 mg, then low dose aspirin, and Lasix 20 mg, gabapentin 100 mg, metoprolol 50 mg, and melatonin. So that's pretty much about the history part.
All right. Well, certainly a rich sequence of information that we're having unfold here. And, I think sometimes getting more clarity on the history simplifies a case. And I think sometimes it can make the case even more complex. And I'm feeling that in this case, the more history that we got adds more and more dimensions to this case here. Because in addition now to having altered mental status and new gaze deviation, we also have to contend with fevers and coffee ground emesis, as well as this background history of atrial fibrillation with rapid ventricular rates. I think for me, I am nowhere near a point in this case where I feel like I'm able to offer up different diagnoses. And so I'll just maybe reflect briefly about how things like the coffee ground emesis and the AFib with RVR are informing how I'm thinking about the initial chief concern. And then Sharmin, I'd love to hear your thoughts on kind of how we tie in the fever and all of this other past medical data into it. I think one of the questions that I have for me is when I see coffee ground emesis like this in somebody who has atrial fibrillation, is on antiplatelet agents, I do start to wonder about the possibility of a GI bleed. And then we have to ask ourselves, well, gosh, how could a GI bleed start to explain some of these other symptoms that we're seeing, like altered mental status and abnormal neurologic deficits? And individuals who have had a prior stroke, if they have any sort of acute global hypoperfusion to the brain, which can certainly happen in the setting of an acute GI bleed, that can unmask prior stroke symptom, right? We call this a recrudescence of a prior stroke. In other words, it's not necessarily that there's a focal hypoperfusion from a clot or a bleed in the brain, but there's global hypoperfusion, and that area is just a little bit more sensitive. And so one hypothesis in my head is, okay, there's a GI bleed, and that GI bleed is leading to global hypoperfusion. The other hypothesis is we look at this and we say, okay, this is somebody who's on aspirin, but actually isn't on anticoagulation for atrial fibrillation. And are we potentially dealing with AFib with RVR and a potential new embolic episode that is leading to these symptoms? What that doesn't explain is the couple of days of altered mental status leading up to this acute change, and it certainly doesn't yet explain the fevers. And so it'll be interesting to see how we can sort of start to wrap all of these things together. But Sharmin, I'm curious, what are your thoughts?
Yeah, I'm right there with you. And I think something that would be really helpful is like her vital signs, right? So if we say, because the question is like, which one are you going to address first? And at first, you just want to make sure this patient is hemodynamically stable. So if this is like a severe GI bleed that has been going on for a couple of days that led to altered mental status, then you want to first make sure you stabilize this patient before we send them to scanner. I am still quite worried. So that is like one hypo. And the other one is that, she might be hemodynamically stable. Then I would want to figure out, thinking about like, bleeding, for example, inside your brain versus like, that is a high stake. So I'm just worried about the brain. So thinking about like this, as you mentioned, the Caesar, the stroke, she has like a reason for, as you mentioned, like ischemic stroke in the setting of her AFib. And also if we kind of take it back and say like, oh, is she having any coagulopathy that is leading to a GI bleed that in turn can also lead to intracranial bleed? So I think there is like many different hypotheses that you can try to tie these things together. But I think your north star would be kind of the vital signs and how stable this patient is, and to be able to kind of further prioritize what you're going to address first. Jack, you want to like comment on the past medical history, or do you want me to go through it?
Oh, go for it.
Go for it.
Oh, sure. Yeah, I think I guess overall what this does for me in terms of thinking about the acute findings that we have here, all of the or many of these diseases could modify or influence the development of altered mental status. Somebody who has CKD could develop worsening renal dysfunction, develop uremia or other metabolic abnormalities that could moderate her altered mental status. The history of the subdural hematoma tells us that there may be that this may be somebody who has risk factors for intracranial hemorrhage, right? In an older individual, we could potentially worry about things like cerebral amyloid angiopathy. That's usually going to be potentially intraparenchymal hemorrhage, but certainly we can also see it in the within the subdural space. And then also maybe there's actually residual deficits or again underlying structural neurologic damage that was left behind from that prior bleed that could make her more predisposed to the development of new neurologic deficits in the setting of overall systemic a systemic illness. So I agree. I think all of these things are sort of moving the dial in terms of how we can think about these two presenting symptoms, but I'm having a hard time necessarily clearly defining the syndrome for the reasons that Sharmin mentioned, but hopefully we'll be able to get some clarity about that with this next bolus of data.
Okay, so let's talk about the next aliquot, wherein we talk about the physical examination. The blood pressure was 163 by 90, and temperature was 38.5 degrees Celsius. Heart rate was 121, and oxygen saturation was 98% on room air. So the general examination was, she was a frail, contracted lady who was not oriented to time, place, or person, and not following any commands. Eyes showed right eye gaze deviation and clear conjunctiva. And the neck examination was limited. The assessment was limited due to severe contractions. Heart was tachycardic and no murmurs were appreciated. On lungs auscultation, coarse breath sounds were heard bilaterally with fine expiratory wheezes in the bases. Abdomen was soft, non-tender, non-distended, and there was mild edema of left lower extremity as well. So this was about the physical examination. Should I talk about the labs also along with it?
Yeah, that sounds great.
Okay. So in the labs, we had hemoglobin was 10.5 and MCV was 88.6. WBC count was 21,000 and platelets were 268,000. Then sodium was 139, potassium was 3.4, chloride was 101, and blood urea nitrogen was 28. Creatinine was 1.03, and estimated GFR was 50. So the blood glucose level was 184, and alkaline phosphatase was 166. AST, ALT were 28 and 19 within normal ranges. Total bilirubin was 1.60. So this is all about the labs and the physical examination.
All right. I can take the physical exam and then pass the mic to Jack for the rest. So starting from the vitals, right? Febrile. And the data that I was looking at the most was the blood pressure, and that's the one that I'll keep cycling it pretty frequently while we're evaluating this patient. And in terms of fevers, the question is like someone who's been altered for a couple of days. Is it the infection that's driving this, or is it a complication of the underlying etiology? You can totally imagine someone who is altered, a high risk of aspiration, right? That can cause pneumonitis or infection that can further complicate things, or an infection with it itself can cause altered mental status and lead to other sequela. What I would say is that, for now, I'm still very fixated on that right gaze a deviation. And this is someone that I would just call a code stroke in the ED to just get the imaging as fast as possible, knowing full well that might not be the entirety of the story, but to be able to get those imaging as fast as possible, especially someone who's not following command, other than the right eye gaze deviation, I'm not getting any other, like probably most hard in the setting of someone not following command to be able to really get a good neurological exam. Um, and in terms of like just to comment on the cardiac and pulmonary exam, especially on the pulmonary exam, this is someone who already has a heart failure, right? And going AFib with RVR. So, that corpspread sounds can be pulmonary edema as well. However, again, these are all the problem lists that I'm creating, but for me is like kind of the focal neurological finding in a setting of altered mental status, a code stroke. I would call it code stroke.
I love it. Sharmin, I think I appreciate so much your analysis of like, is the fever a cause of the altered mental status or a complication of the altered mental status? Because I think that the aspiration pneumonitis hypothesis or an aspiration pneumonia that she may be developing is such a brilliant point, because I think the hunt for an infection is really what the labs tell us we need to do, but that hunt needs to happen in parallel for the evaluation of a stroke, exactly as you mentioned. So I think overall, what her labs show is they sort of further support the need to pursue an infectious workup at first, right? We see tachycardia, fevers, as well as a leukocytosis, and now we have, which puts us in sort of, this is somebody who's meeting SIRS criteria, right? Or if you like QSOFA, right? We say that we have signs of sepsis here, and now we have to go discover that source of sepsis. The exam findings, right, may clue us into the possibility of a pulmonary infection. The extremity exam actually becomes interesting here, because if we see that there's the asymmetric extremity or the asymmetric extremity swelling in the left lower extremity, it's like, okay, is there a blood clot here? Maybe that also further influences what Sharmin was saying about a hypercoagulable state and the increased risk for a stroke. And then also clots can be nitises for infection. Someone who's bacteremic and has a blood clot can develop septic thrombophlebitis. But I think with the white count and all of these things, as we await the code stroke results, we're going to focus on at least initial evaluation of those 5 common inpatient infections. Going to look for pneumonia, a urinary tract infection, a skin and soft tissue infection, hepatobiliary or gastrointestinal, and then also a bloodstream infection. And that workup can happen sort of right before or right after she gets back from the CT scanner. And then I think once we have clarity on what's happening neurologically, it'll really help us understand whether or not we need to pursue the possibility of a CNS infection with something like a lumbar puncture.
Okay, that was amazing. So we can now shift over to the imaging tests. CT head was done, which showed no acute intracranial findings, and old infarcts were noted, and parenchymal volume loss was seen, and small vessel disease changes were also seen. There was evidence of acute pansinusitis. Then chest X-ray was, no acute disease was noted. It was insignificant. And CT abdomen and pelvis was done, which showed right lower lobe airspace disease and distended gallbladder with gallbladder stones. Apart from that, there was no definitive acute intra-abdominal process which was detected. So this is about the imaging part.
All right. So what we can say from the CT scan is that the cause of her neurologic deficits is unlikely to be from a bleed. But what we haven't necessarily ruled out is the possibility that they are from what's the right word? An embolic event, or from a atherosclerotic rupture, or basically a non-hemorrhagic stroke, right? We ultimately need the MRI to fully falsify that hypothesis. So we can say that there's no intracranial bleed, but again, the stroke possibility is still on the table. The chest x-ray, right, decreases the probability of a pneumonia here, but there can be chest x-ray negative pneumonias. Roughly 10 to 15% of folks who come into the hospital with community-acquired pneumonia may have a negative chest x-ray, but a positive CT scan. So we have to ask ourselves, do these coarse breath sounds warrant exploration of a pulmonary infection with a CT, or do we say that we've actually exonerated the pneumonia hypothesis? I think for me personally, I've seen enough sneaky pneumonias come up in the retrocardiac area or be hidden by the cardiac silhouette, or just be in a very open area, but for some reason the x-ray doesn't pick it up. So I think given the breath sounds imaging, maybe cross-sectional imaging is in her future. And then when we look at the abdomen, right, we see a distended gallbladder with stones. And we may say, well, there's a possible infection. This distended gallbladder with stones could be evidence of cholecystitis, right? Our exam findings are limited in the sense that we may not get some of the classic exam findings from an encephalopathic patient that we look for in cholecystitis. For example, a Murphy sign is very difficult to obtain in the setting of encephalopathy. So one way to approach that is to say, well, gosh, the distended gallbladder and stones may be a signal that there's cholecystitis, which can certainly have relatively normal liver enzyme abnormalities that we see. But the alternative hypothesis is that her gallbladder is distended not because it's infected and obstructed, but just because she hasn't eaten in a long time, so there hasn't been a stimulus for that gallbladder to contract. And in the absence of seeing things like pericholecystic fluid or gallbladder wall thickening on the CT scan, I have a hard time saying that this is definitely, for example, something like cholecystitis. And that matters because as we look for a possible source of infection, the combination of fever, altered mental status, and no other clear localizing infection makes us have to at least ask ourselves, is this somebody who needs a lumbar puncture to fully exclude the possibility of a meningoencephalitis? So I think that's the real decision point that I'm grappling with in my head at this point. Also, cystitis or a UTI comes into play here. But even if she had a positive UA, I would have a hard time saying that that's definitely the infection because the fever and the altered mental status seem to be such a dominant syndrome here. So yeah, I think that's overall where I'm at. I think the hunt is still on for a source of infection, and also the possibility of an intracranial vascular process causing this eye gaze deviation, I think is also still looming in the background. What about you, Sharmise?
Yeah, I just love your reasoning. It sounds like the chest x-ray gave us some right lower lobe airspace disease opacity. So that potentially could be another story. I totally missed that too as well. I totally missed that.
Thank you.
Thanks to the chat.
Struck from the record.
Thanks to chat for pointing that out. So I think again, someone who had MSS is that a brewing pneumonia or that the pneumonitis type. So definitely another potential source to add to the gallbladder issue that you mentioned. And what to do now, right? Sepsis, we have two potential sources. So IV fluids, antibiotics. She has a history of heart failure in the past. However, I would say, heart failure patients can get septic as well. It's important to hydrate them and keep a very close eye on their volume exam. Start antibiotics, and I'm still puzzled with this right eye gaze. I'm very reassured that at least she's not having a big hemorrhage, but then is this someone who needs further imaging, like an MRI, that you have to if you MRI in someone who's encephalopathic, do you feel comfortable laying this patient flat for the duration of MRI is one thing to think about. And the other aspect of it is whether this is a seizure. So this is someone that I would want to evaluate for potential seizure and then think about when it would be a good time to get additional brain imaging and treat for an infection, again, like lung, or as you mentioned, gallbladder. I'm still trying to figure out what led to what, right? Was it an infection that led to altered mental status that led to MSS? Maybe coffee grounds. That's another trending. The hemoglobin would be informative. And sometimes you just need a bit of time to see where the data and getting more history from the family, and also just like this patient declaring themselves. So I would monitor her vitals closely. I would monitor her hemoglobin closely. I would start antibiotics, think about give fluids and monitor, and potentially asking our neurology folks whether this is someone that they would want to um, evaluate for a seizure as well. Jack, any other thoughts?
No, I think the one other thing that I'm in my foray into the phantom chest X-ray that I forgot to mention was the sinusitis on the head CT, and I think that this is a tough thing to deal with here, because I think um, it is something that we see occasionally, and that less often, but certainly it can happen, represents actually a really, really morbid finding. And I think if we were to say that there was pansinusitis in the setting of this sort of overwhelming picture of sepsis and fevers, I don't know that I would make much of it, to be told, right? There is a clear alternative potential causes of an infection. But the presence of the eye gaze deviation plus the sinusitis in the setting of someone who has diabetes does start to make me wonder if it's something that has to be explained, right? Because altered mental status plus a systemic infection, very, very plausible. Altered mental status plus a systemic infection plus a focal neurologic deficit, less plausible, but certainly possible. And as we said, the mechanism for that being the recrudescence of prior stroke symptoms. But now with the sinusitis findings, right? If we were to sort of look at a cross-sectional view of the head and the sinus cavities, it is not a far distance between the sinus cavities and many of the structures in and around the eye, including the muscles and some of the cranial nerves. And there is a syndrome called orbital apex syndrome that can involve basically infections that make their way from the sinus cavity, most characteristically invasive fungal rhinosinusitis like mucor, into the backward portion of the eye. Now, orbital apex syndrome does not present like what this patient has. There's usually vision loss because the optic nerve is involved, proptosis because there's an infection behind the eye at the orbital apex, and then you can see deficits in the extraocular movements. In this case, what we're seeing is only abnormalities in the eye gaze deviation, but I do still wonder, right? Cranial nerve 3 passes through and close to the cavernous sinus. And so the sinusitis on exam makes me even more worried about, or I think the sinusitis on exam in the setting of this neurologic deficit of the eye gaze deviation, I think increases the probability that is actually not necessarily noise, but actually potentially signal here. And so I think that even further supports the need for the MR imaging, because we'll just get a much more precise, more high-def view of what's happening in and around that area of the cranium.
That is such a great point. And yeah, so mucor is such a great thought here. And also, like, if you have sinusitis, even bacterial meningitis, it can happen too. So yeah, I feel I'm liking LP here too.
Yes, we have the final aliquot says we have the lumbar puncture reports as well, which says the CSF protein level is 275. The CSF glucose level is 79, and it is on physical examination, it's yellow and cloudy fluid. Xanthochromia is absent, and WBC count of CSF is 20,000. The predominant part of which is neutrophils, that is 71%. And CSF PCR shows that Streptococcus pneumonia was detected in the CSF. And then it is the diagnosis is made of acute bacterial meningitis.
Oof. Yeah. I'm glad we were on the right path. You never want to miss. We talked ourselves into, as Jack did with his guidance, to thinking about what could go into the CSF. But yeah, absolutely, like acute bacterial meningitis. Again, it's hard, right? This is someone who presenting septic, but because of like the body habitus, you might not get the neutral rigidity, the headache. You just kind of someone is like presenting with more altered, and I'm really, really glad this you guys did an LP, and this is someone that at least like with the CT doesn't have a space occupying lesion, so getting the LP and then starting on antibiotics. This is someone that should get some steroids as well before the strep pneumo, and then getting the Vanc ceftriaxone. Wow, what a case, what a journey. What did anything come out of the ground coffee MSS by any chance? Was she ever had a repeat of that episode?
No, that was I don't think it was the main that wasn't repeated. Maybe I was reading in the chat that because of her CKD, the uremia thing, her platelets could have been dysfunctional, and maybe that led to the upper GI bleed somehow.
Okay.
But about this case, I found an interesting finding that glucose in the CSF was 79, which is quite towards the higher side. And we say that in bacterial meningitis, glucose is on the lower side. And then I researched about it, and I realized that her serum glucose is 184. So relevant to her serum glucose, her CSF glucose ratio was equating to bacterial meningitis only. And that was one point I found really interesting. And secondly, also, since it was suspected meningitis, we could not do LP directly. We had to go for a CT head because because of the fact that she was altered. She had altered mental status. We could not go for LP because we had to rule out some intracranial if masses were present, because otherwise it could have led to brain herniation. So on CT head, there was no evidence of any intracranial mass or anything like that. And then we could go towards LP, and which revealed the presence of the strep pneumo. And even before that, in fact, we have to give the empiric antibiotics, and in this case, which are the ceftriaxone, vancomycin, and ampicillin. And even before that, we take the blood cultures. So it is actually the management of meningitis, a very interesting thing, which I actually realized while presenting the case. And I really thank you guys for this opportunity, because I learned a lot along the way.
Well, thank you so much. You are getting a whole lot of love in the chat that I hope you take at least a minute or two to soak in there. An absolutely brilliant presentation. Just the way that you laid it out, the way that you told the story. I just want to say thank you for both the time and the energy and effort, and just clear commitment to doing an exceptional job of this that you brought to it. You did so in spades. Gerardo and Tansu, thank you both so much for scribing and for the teaching points. This was an incredibly educational case. For me, I think one major learning point is, cranial nerve deficits are not oftentimes on my radar as a clear signal for bacterial meningitis, which I'm excited to get to learn more about later today. But yeah, thank you all so much for an amazing case. Sharmiz, thank you as always for a brilliant discussion. And Tansu, take us home with the teaching point.
All right. So we started off with a 94-year-old female patient who had altered mental status, and she also had new onset right gaze deviation. And normally we would go by the Miss Mnemonic to investigate the causes of the altered mental status. But in this case, we had an older patient, so we decided that we should prioritize imaging to rule out the do not miss causes, such as subdural hemorrhage and intracranial bleeding. And then the right gaze deviation was also very interesting. So we should investigate if it's in both eyes or single eye, or if there's this conjugate gaze, and cranial nerve palsy should be something to keep in mind here too. And since we had the eye finding, there is a higher probability for intracranial process than a systemic infectious process. And this patient didn't only have altered mental status, but she also had baseline dementia, coffee ground emesis, and she was febrile. She also had AFib with RVR. So given her medical history, we have many possibilities to investigate here. So the patient was on antiplatelets, and this could be causing the GI bleed. And since she had the prior stroke, acute derangements could impose on this prior stroke and would be causing acute global hypoperfusion due to GI bleeding. And since the patient wasn't on anticoagulations and she had atrial fibrillation with RVR, could this be an emboli that's causing her symptomatology? And then she had CKD, and is she altered because of uremia? So we also thought about cerebral amyloid angiopathy. And since we had so many problems, we thought about which problem are we going to address first. So first, we will address the patient's hemodynamic stability. And then we need to figure out if the bleeding is in the brain and possibly investigate coagulopathy. And vital signs of this patient helped us prioritize what to address first. Since she had fever, we prioritized infection, and we were looking for a source of infection. And we thought about 5 possible routes: the UTI, community-acquired pneumonia, skin soft tissue infections, GI causes, and bloodstream infections. And then Sharmin said we should immediately call the code stroke, and imaging should be done ASAP. LP should be obtained to rule out meningoencephalitis, and seizure evaluation is also necessary, and antibiotics should be started also as soon as possible. And then we talked about, even though this patient had a negative CT scan and the bleeding was ruled out in the CNS, but it could be non-hemorrhagic stroke, so MRI is also needed. And chest X-ray was negative, but it could be negative in pneumonia, so CT scan is also could be needed here to really rule out pneumonia. And in the end, because of the eye deviation and the evidence for sinusitis on imaging, we thought about orbital apex syndrome, and we were sure that definitely something is going on in the CNS. So we prioritized getting further imaging with MRI and LP, which revealed the final diagnosis of strep pneumonia, acute bacterial meningitis. That's all from me.
Whew. Feeling the heat today in the best way. Absolutely fire, Tansu. Thank you so much. And yeah, thanks everybody for a fantastic VMR. Hope everyone has a great rest of the day. Anmol, I hope that you have a great day that is starting very, very early today. Thank you again for coming to join us. And yeah, we'll see you all next time. Take care, y'all.